Hello and welcome to webinar series. Again, Shanti here this side, and today's topic for discussion is all about monitoring of neuro patients beyond the routine vitals. And for this discussion, I like to welcome none other Dr. Vishwanath Garu, who is our consultant neuroanesthetist and neurocritical care from Yashoda Hospitals, Secunderabad unit. And we all are happy to have you with us, Dr. Vishwanath.
Thank you.
And so too, I like to welcome all our speakers in the panels. Miss Swati, who is in charge in neuro nurse from City Neuro Hospital, and Miss Aditi, OT nurse manager from Yashoda High Tech Unit. And we do have Miss Ansi Libin, a senior nurse from Bilai BM Shah Hospital. I welcome you all.
Thank you,
Yes.
ma'am. Thank you.
And yes, we are going to keep this session very time bound, and let us see what we have in the rest of the discussion. Over to you, Nancy. Yes.
Good afternoon, everyone. My name is Ansi Leben. Every opportunity to learn is a step towards better patient care. And I'm grateful to Yashoda Hospital, directors, management, especially Shanti ma'am, for making this inspiring learning experience possible. So let's stick to the topic, why neuromonitoring is different. As you can see, the beautiful quote written in the slide, routine vital signs tells us how the body is functioning, but neuromonitoring tells us how the brain is surviving. So, one interesting fact I came to know that brain has no receptor. Then how can we feel pain or headache when the patient complains like I having headache? So in the bedside it is very usual to know that this complaints has been noted by the patient. What are the usual complaints of the patients are like sudden drowsiness, confusion, irritable, not following commands. So behavioral changes is the vital role that plays in neuromonitoring. So, sir, I want to know that while doing brain surgeries, he can be the patient will be like awake, or he can be normal, or he can talk. Over to you, sir.
Good afternoon, everyone. So, as you said, it's correct. Yes, brain senses the pain from rest of the body, but brain per se does not have any pain receptors. Okay, it will take the sensation from all the body. Whenever we feel pain, it is all sensed by our brain, but brain per se does not have any pain receptors. So that's why when you do awake anatomy, even if you open till the dura, patient is having pain sensation. Once the dura is opened, so below that you don't have any pain receptors. And one more thing, why neuromonitoring is very essential beyond what you said, like vitals. See, what vitals regularly we monitor: saturation, SpO2 or heart rate, ECG, BP. These are all measuring only the two systems. One is we are monitoring cardiac system and is the respiratory system. Okay.
Yes.
So otherwise, if you see the most important organ, what we say, it's a brain. Brain is also equally plays important too. As such, a routine practice, what we have regular practice, we are not trained enough to do monitor the brain. Because see, if you see BP, BP, take heart rate, saturation, these are all tells only about the respiratory system, or saturation tell the your cardiac system. So
Yes.
monitoring brain is also equally and essential. Even the patient with the, suppose if the patient is brain dead patients also has the respiratory rate. Even the patient with the bend rate, they'll have all saturation, your heart rate, BP, everything will be normal in brain dead patients also. That's why it is very essential to monitor the brain, because it's a irreversible damage can happen. Brain, once the damage happens, that the damage are irreversible to the brain.
Irreversible, yes.
Very true.
And yes, a very productive insight you have provided, that we have not enough trained our brain. Yes, as only we just monitor cardiac and respiratory system. Yes. Going forward, as yes, Swati, what you wish to learn from sir? Yeah.
Good afternoon, sir. Good afternoon, ma'am. Myself, Swati, and I'm from City Neuro Center, Banjara Hills, Nursing in charge. So, as you, we sir said, we know we did just see check the vitals regarding the saturations and heartbeat and the temperature and all things. But it is most important for the to know regarding the neurological vitals. So what parameters should be measured in terms of neuro monitoring for neuro patients beyond the routine vitals, like GCS, pupils, consciousness, motor, and memory, sensory checks,
Yes.
and intracranial pressures. How we can check the neuro monitoring when the patient is under sedation, and what fluid intake and output should be monitored, and how the seizure activity should be understood through those ECGs are advised. And if the patient is under intubation, how we can means how we can find the we can do the patients, analyze the patient's conditions,
Mm.
as rapid response and management is very important for the nurses to understand. Over to you, sir. Thank you.
Uh, as you said, regularly, other than we all regularly what we monitor for brain is your GCS. We all know that eye opening, verbal response, and motor response, what we see regularly for that, and other than pupil monitoring. Other than this, what brain monitoring can be done, there is something called, suppose brain is a cranial cavity. One thing, how good is the brain blood flow to the brain? How good the blood flow to the brain is happening? That can be monitored with the TCD. There is something called transcranial Doppler, which tells how is the blood is flowing to the brain. Second thing, what is how is the electrical activity of the brain? How brain there in normal electrical activity or abnormal activity? Abnormal electrical activity can be picked up by your EEG. The patient can have a different type of seizures. The seizure can be a focal seizure or generalized seizures. The patients who are high risk, the patient who are any intracranial pathology, they might initially might not throw suddenly the generalized seizures. They might have focal seizures. They'll upper limb movement or lower limb seizure or facial deviation that can be picked up prior only. And there is something called ICP monitoring. ICP monitoring, like what exactly the pressure inside the brain can be monitored.
Yes.
Like, sir,
Yes, Swati.
how we can monitor these ICP monitoring? Is there any any special monitors for checking this
Yeah.
ICP monitoring? Yeah.
So as you said, very good. The ICP monitoring is very essential, very crucial, especially in a high risk patient, the patient who have raised intracranial pressure. So why ICP monitoring? Because very important is brain is contained in the closed cavity. It is inside the skull. Because any change in the pressure, so initially it will accommodate till to reach a certain pressure. After certain pressure, there is a sudden rise in intracranial pressure that will lead to the herniation of the brainstem. That the patient will lead to the irreversible brain damage. Patient will go to the brain death. So there are many steps we can take care so that further rise in ICP can be decreased. The ICP monitoring, there are different modalities. There is invasive or non-invasive. Non-invasively, you can monitor is optic nerve sheath diameter, which is non-invasively you can monitor in your OT in ICU setups. Other than the invasive monitor, we like like whatever EVD, external
Yes.
ventricular drain, what you place, that can be transduced. How you transduce your arterial to the
Arterial pressure.
same
Yes.
pressure, you can transduce your EVD to the arterial pressure. With that, it will give a waveform and it will give a pressure value that can be monitored. That is becomes very invasive, and only important, crucial, important thing what to know. Take care of these things. There is high risk of infections when you are handling a EVD. So you have to
Yes.
make sure that you are making all aseptic precautions you are following. Other than the, you know that a normal ICP is less than 15, we consider it normal. Anything around 20, it's a well, it's red sign. There is mild, moderate elevation of ICPs. So significant whenever ICP goes beyond certain level, because there is any intracranial pathology, then we have to
Yes.
go for CT scan. Then we have to go for look for the underlying cause. We might needed any decompression surgery or CSF analysis. When we place EVD, if the ICP goes high, little bit of CSF can be removed from the brain so that the pressure comes down.
Yes.
Sir, I would like to ask when ICP, as you said, beyond the 20 mm, it is increased. That is the like a red flag for the neurological patients. So when ICP is above 20 mm, what is the first nursing intervention before the doctor arrives?
Yes.
Over
Yes,
to you.
it's a very good question.
Very good
No,
question.
suppose
Yes.
assume that you are monitoring a ICP brain. See, brain is contains in a very closed cavity. I
Yes.
said brain. It is a skull. There's a brain. But inside that, what we have as contents are one is a brain parenchyma, CSF, and blood. These are the three components are there. What happens? Suppose you assume that suddenly ICP is going high. You elevate the head end. The moment you elevate the head end 45-degree, the venous return, the whatever the blood is there in the brain, it will slowly comes down. If the patient is agitated, try to sedate the patient. Suppose the patient sedate, by sedating the patient, what you are doing, you are decreasing the electrical activity. The more oxygen requirement for the brain, more you sedate the patient, the oxygen requirement of the brain comes down, the blood flow comes down, so that ICP comes down. Suppose if the patient is on ventilator, try to little bit hyperventilate. Respiratory rate is around 12, you make it 14 or 16. By increasing hyperventilating, you are doing what happens? There is a cerebral vasoconstriction that will decrease the your ICP. These are necessary
Yes.
precautions we can take. Immediately inform the your doctor, and you always
Doctor.
make sure you check the pupils also.
Yes.
Okay.
Yeah.
Okay. So one more question I would like to
Yeah. Yeah.
ask.
Please.
What is the earliest clinical sign of raised ICP that nurses should never miss?
So
Yes.
there are neuro patient and non-neuro patient. Neuro patient ICP first sign what you say always look for one thing is a patient GCS. There is sudden drop in a GCS. Okay, patient become a aphasic. Patient throw a metaseizure. And one more in a vitals. If you are having a monitor, if the patient BP going high and heart rate coming down, that is the earliest sign. Like you can make out that the once the ICP will become something called Cushing reflex. Once the pressure inside the intracranial goes high, the body try to increase the pressure because cerebral the cerebral perfusion pressure is equal to mean arterial pressure minus ICP. Once the ICP
Yes.
goes high, body try to perfuse the brain by increasing the mean arterial pressure. Once the mean arterial go high, there is a reflex bradycardia. So there is a pushing reflex you have to look and look for the GCS and look for any through seizures. These are the important things what you have to look in the earliest sign, especially in the
Yes.
high risk patients.
Yes. I think, as you mentioned, Cushing's triad, I think we miss this terminologies. Yes. Yeah, going forward, as you have, told all the parameters, yes, Aditi, what you wish to understand, yeah,
Very
in
good
a different
afternoon,
way.
sir. Myself, Aditi from High Tech City, Yashoda Hospitals. I'm working as a senior nurse manager. It's my pleasure being a part of this webinar. So, my question here is how important is escalation of the nurses regarding any of the parameters to the doctors? Like, as we say, GCS drop down to 2 or more from the baseline, or new ability of the following commands like localizing pain, like pupil changes also if it is sudden dilation is more than 5 mm, or not reacting to light, or motor changes like weakness in the limbs or seizure activity. Brain is in a closed box. So how do we understand that this parameters, wherever it is required to be escalated to doctors, how important is it for the nurses to do it on a real time?
Especially in
So
terms of monitoring GCS, because as we go with this, we do have this record in our case sheet, but
Yes.
then still we see little lacunae and lapse, when the patient's reading is mild, moderate, and severe. We still do not see the escalation matrix going to the doctor. Yes, over to you, Dr. Vishwanath.
So as you mentioned, any drop in GCS of more than 2 points, okay, there will be a verbal response, it can be motor response, or
Yes.
if you notice there is even pupillary response also. If you notice there is a drop in GCS, immediately you have to escalate to the doctor. Why important? Why it makes important is, see what there is something called Monroe-Calculin doctrine hypothesis. What happens is the brain, because the skull initially it will start slowly once the ICP start going high, the brain is like skull cavity, it will try to accommodate without increasing the pressure. The pressure it with the ICP, the volume increases inside the brain without increasing the pressure. At one point, there is sudden shooting of the pressure because the further rise in any volume, it will not accommodate. That is where your untoward events happens. If you reach that point, that means there is irreversible damage has happened. There is a cutoff of circulation, brain stem infarction, brain stem herniation happens. So it is very essential pick up as early as possible. We have a lot of window period so that address it so that it can further permanent damage can be prevented. So how you can do is, and when you are monitoring pupil, so you always keep document on the pupil. Suppose
Yes.
what any further dilation, 2 mm change or any jaw drop in GCS. We always say that when the GCS goes less than 8, suppose 8 or less than 8, immediately we have to intubate. But
Yes.
irrespective of what is the patient condition, if the GCS is less than 8, there is always guidelines that you have to intubate the patient, secure ABC, like airway, you have to secure, make sure that vitals are stable. That's why
Yes.
monitoring GCS along with the pupils, along with these things, very much important. You have to escalate so that permanent injury can be prevented.
Prevented. Yes. Very well said. Yes.
Yes,
And as we have discussed about this, Cushing's triad, and yes, Ansi, I think in terms of cerebral perfusion, you can just learn from Dr. Vishwanath. Yes, over to you.
uh, Red flags in vital signs. We can see a systolic blood pressure below 90 mm Hg and above 180 mm Hg can reduce cerebral perfusion pressure. Bradycardia can happen anytime, less than 50 heart rate we can see with hypertension. That may raise intracranial pressure. And we must see that the SpO2 less than 92% or a respiratory rate less than 12 can also be a red flag for a neurological patient. So, sir, I just want to know that how can we differentiate between the consciousness and the deterioration that is happened due to sedation?
Okay. The one more important point about your blood pressure you monitored, I want to highlight here is brain
Yes.
is something called, there is something called auto regulation. Brain control, our brain is like autonomic institute kind of thing. Like what it does is, whatever the BP goes high, whenever the BC goes lower also, the amount of blood what is required from the heart, it will take that much only. It will not, neither it will, suppose the BP is going high, it will not take extra blood, or if it BP going down, it will not take more less blood. Even the range of, like, if you say this BP of almost a 90 to 180, in that range, the blood flow to the brain is constant. That is what called as auto regulation. Beyond 180, if the BP is going high, that means there is auto regulation break, that blood flow is more than what is required to the brain. That is where intracranial bleed can happen. If the blood pressure comes less than 90 in a conscious patient, the blood flow will come down, because the pressure, it is auto regulation is maintained between 90 to 180 only. If the blood pressure comes less than 90, the blood flow will come down. There is a ischemic changes, because the hypoxia will happen. The hypoxic changes can happen. So coming to the what you asked, like sedation, how to differentiate between sedation related unconsciousness or patient GCS drop. Always
Yes.
when you give a sedation to any patient, the breathing pattern always you have to see. Breathing pattern, if the patient is breathing pattern is normal, that there is most of the time it is sedation related. If the patient is having irregular breathing, always in Cushing reflex, what we say, hypertension, bradycardia, and irregular breathing. The breathing pattern is not regular, and patients always see the uprolling of the eyes, okay, any deviation of the
Yes.
eyes. These are all
Yes.
signs will tell that these are not because of the sedation, it is mainly because of the some intracranial pathology. And obeying commands, at the same time you give, just even if sedate the patient, you give painful stimulus, patient will wake up if you give painful.
Yes.
Whereas if any intracranial related thing, even if you give a painful stimulus, patient will not be able to wake up. That is how you have to differentiate between sedation related things or intracranial related your drowsiness.
Yes. Yes. Yes, this is a very quite interesting session, and I don't think that it is going to be just finished within 20 minutes of time, as you have clearly told about the neuro red flags and including the ICP monitoring and escalations towards the same. So here, I wish to understand, as I've seen a lot of your articles, you have published, and your talk also I have seen, like, what is awake brain surgeries like? Are do I should I think that patient undergoes surgery while talking to you all by being awake and conscious? Yes. So what do you? I think this is the
So,
one interesting
uh
fact which
yes,
you
okay,
wish to
I can
understand.
enlighten on this, because suppose you have
Yes.
a brain tumors. Any brain tumor, if you operate nowadays, what we do is, there are in olden areas, whenever the surgery is done on a brain surgery, after that surgery, the patient will always have one upper limb, lower limb weakness, one side
Yes.
hemiplegia. That was a
Yes.
concept previously when any brain surgery. Now
Yes.
we are making sure that any brain surgery, patient quality is important. It is not the quantity of life. At the end, whatever amount of life he leads after the surgery, it is the quality of life, his independent life he is living, that is what important. So when brain tumor is, suppose if it is lying very close to the speech area, okay, is inside the brain, the speech area is present in your frontal lobe, left frontal lobe is close to the very speech area. If you operate, if you like, if the patient do on general anesthesia and operate it, patient after waking up, patient will not be able to speak because we have damaged the speech area. So how to monitor this? So what you have to do, you have to keep the patient conscious. While the surgeon is removing slowly tumor, you should keep interacting with the patient so that his speech is intact. So what we do, we'll give some task to the patient. We'll ask the patient to count the numbers 1 to 10 or 1 to 20 in the reverse direction. And we'll try to identify we'll ask him what is his routine, like what is the family members' names.
Yes.
So these
Yes.
are all will try to keep interacting with the patient so that his speech area is intact. The moment surgeon goes very close to the speech area, then he'll start having speech arrest. Suddenly he will ask 1, 2, 3, 4, 5, 6, 10. You ask him to come 1, 2, 3, 4, he'll stop. Or 1, 2, 3, 4, 5, he'll
Yes.
stop. So that is where he will inform the surgeon that you are close to the speech area. I think you should not dissect in that direction, change the direction or to stop the surgery. This is what awake surgery. Either patient tumor in the speech area or any motor area. Suppose patient is hand area tumor, we'll always ask the patient to move the hand during surgery. So till the time he is moving hand normally, we'll trigger on resecting the tumor. At one point comes where the patient further resection, patient might start having slightly weakness and all. We'll stop it there so that patient will returns in normal function. Then that's how we do the awake random. Mainly in a eloquent area we say, motor area
Yes.
and speech areas.
Yeah, the wonderful updates, very interesting, as you said, the Broca's functionality. Yes. And what kind of anesthesia do we give, sir? Because patient is talking
Yes.
and you're giving the task. So I just wanted to know because, yes, you are the expert. So,
As we said, brain parenchyma per se does not have any pain sensation. So one thing what you have to give, you have to give adequate scalp block so that when surgeon is done craniotomy, if you are completely make his scalp numb, okay, that is what we do, the scalp block we say. So if you make this numb, after that we'll give little bit of sedation with the remifentanil or dexmedetomidine so
yes,
that
yes,
lightly patient is not become apprehensive during craniotomy. So only that much scalp block with little bit of opioid or demifentanil or dexmedetomidine. So with that, we'll get it done. Once when we have to assess the patient, at that time you will stop all the sedation. You'll start interacting the patient. And more important in awake anatomy comes is the patient counseling before surgery. Because for us it is a routine. For the patient is a first time. So he might become
yes,
apprehensive. We have to create a simulation like OT is new for him. Awake anatomy is new for him. So you have to proper thorough counseling how
constant.
things will go on, why from step one, like from placing the IV line to the pacing the pins, doing craniotomy, doing other different sounds in the OT. So all suctions, sounds, QSAR, drill, everything you have to tell them that. So better build a better rapport with the patient.
Yes.
Then you can execute your plans accordingly.
Oh, very great to understand the wonders of brain and the skilled hands which you all have. Yes, great to know this about. Yes, and we are just approaching towards the end of the slide. And yes, Aditi, and then we end the session. Yes, Aditi.
Thank you, sir. Thank you for such a wonderful information. As well said, that we need to have a clear monitoring on all the aspects when it is a neuro-related surgery or a neuro patient. So when it comes to neuro, obviously we need to understand that the patient might have dizziness, drowsiness, so we might have a very high risk of falls. So here we need to go by the IPSG goal 6, that is prevention of falls, by making sure that the patient has been properly mobilized onto the bed by putting the side rails and making sure we have a fall risk board.
So one more
And
thing is many
yes,
times
sir.
neuro patient they will be unconscious before going surgery. They will not be able to tell. Many times what happens in other surgeries and all, what happens if we go to patient surgery, we'll ask the patient itself which side, which like some TKR surgery, we'll ask which leg you want to get operated. Patient. Whereas in neurosurgery they will not be able to tell which side is the pathology, which side to be operated. So you
Yes.
have to be very careful with the patient identification and site identification.
Right,
Many
yes.
times what happens, yesterday we were doing one case, like with the seizure surgery, even MRI also looks normal only in that patients when you are doing MRI, MVD surgery. So that's why identification, the correct site and side is very much essential in neurosurgery. Fall risk, because they're all drowsy, we have weakness, sometimes one upper limb
Vulnerable.
weakness. The fall risk also is very high in these patients.
Yes, sir.
And Dr. Vishnath, whether we should consider it as a side or site for brain surgeries.
Usually brain surgery site is anyway, you know, that brain site, any
Yes,
side
yes.
is very important.
Site
Because
is
what happens,
important.
side,
Yes,
the right,
yes,
if suppose what happens, there is a right side increase ICP on the right side. Okay.
yes,
So you have to operate right side. But rather than if you open the brain this side, the entire pressure will come opposite side. The patient will
yes,
collapse on table. If you operate wrong side in the any raised ICP, the patient collapse out and it is medico legal criminal negligence. So if you are
right.
operating in wrong side, it's a criminal negligence.
Yes, yes. Yes, a very, the cerebral pathologies are very, very critical. And so we do have able expertise like Dr. Vishwanath and Dr. Rajesh and a lot of other, neurosurgery clinical fraternity over at Yashoda. Yeah, we end the session here. I thank you, Dr. Vishwanath, for your very crisp and very valuable update. I do thank the speakers, Ansi, Aditi, and Swati. And I urge all the viewers to just refer www.yashodahospitals.com for more such updates, academics, and also watch patient testimonials for evidence-based learning. Yes, and we end the session here. Thank you.
Thank you
Thank
so
you.
much, ma'am, for the
Thank
opportunity
you.
provided.
Thank you.
Thank you,
Thank you
sir,
so
for your
much.
insights.
Thank
Thank
you
you.
all. Thank you. Nice,
Thank you.
nice interacting.
Thank you.
Thank you.
Thank you,
Yes.
sir.